Good morning and welcome back to this YouTube channel. In this video, we talk about subtalar joint arthrodesis. The question we must immediately ask ourselves is, what is an arthrodesis? It is simply the permanent blocking of one or more joints. The joint is the mobile part between two bones that come into contact, and therefore, this mobile part is rendered immobile. This procedure is performed in cases of advanced and painful osteoarthritis, or in cases of severe and uncorrectable deformity, such as in patients with neurological problems. The most common reason for this procedure is osteoarthritis. In our case, the problem, whether arthritic or neurological, affects the subtalar joint, the joint between the talus bone, which is part of the ankle, and the heel bone, which we call the calcaneus. Many cases of subtalar osteoarthritis are the direct consequence of a previous calcaneal fracture. This is an uncommon fracture, occurring primarily after a fall from a height. A subtalar joint problem causes pain and stiffness, particularly during pronation and supination, but also makes it difficult to walk on uneven terrain, such as on a meadow or in the mountains. As for treatment, before considering surgery, one obviously always considers the least aggressive options, including oral painkillers, physiotherapy, or the use of custom-made insoles. However, to effectively reduce pain, even if only temporarily, there are joint injections that are performed under X-ray control to ensure the needle is in the right place. In the short video you see now, I show you a typical example of a joint injection under X-ray control. In this case, it involves an ankle injection, not the subtalar joint, but the concept is essentially the same because the method used to perform the injection is exactly the same. In general, infiltration involves the use of a mixture of cortisone and local anesthetic, although there are alternatives such as hyaluronic acid or platelet-rich protein, PRP. For more information on how infiltrations are performed and the products that can be used, I invite you to watch the video linked at the end of this presentation. Often the only option is surgery. Anesthesia is almost always spinal, that is, through an injection in the back, or general anesthesia. Generally, however, the anesthesiologist will also administer peripheral anesthesia in the calf, under ultrasound guidance, to ensure pain-free postoperative care. The surgery involves cutting the skin a few centimeters long, along the lateral edge of the foot and under the lateral malleolus of the ankle. Through this incision, layer by layer, we reach the subtalar joint, which you see here. At this point, we use a self-static distractor and widen the space between the two bones, which I remind you are called the talus and the calcaneus, which are the upper and lower bones respectively. The self-static distractor helps us work comfortably. In particular, the crucial part of the procedure is to remove the diseased cartilage, using scalpels and gradually removing the cartilage debris. Once all the cartilage has been removed, we're talking about a layer no thicker than 2 millimeters. We reach the layer of bone immediately beneath the cartilage. To heal the arthrodesis, we must use fixation devices, which in most cases consist of screws with a diameter ranging from 6.5 to 7.3 millimeters. We generally use 2 or 3 screws that can remain in place indefinitely. The screws will be removed only if they cause discomfort, and only once the bone has completely healed. The screws are inserted through small incisions in the skin and are intended to stabilize the arthrodesis and, above all, provide compression between the two bones, thus ensuring optimal healing. Once the screws are inserted and final X-rays are performed, we close the wound using absorbable sutures that will then fall out on their own. After suturing, a sterile dressing is applied, which will be changed by your surgeon or wound care nurse, typically once a week. After the operation, which usually lasts about 60 minutes, you will not be able to walk with your full weight on the operated foot. For this reason, you will be prescribed low molecular weight heparin prophylaxis to reduce the risk of deep vein thrombosis. This medication is injected through a small, painless needle and is certainly more manageable than oral anticoagulants, which increase the risk of bleeding or problems with the surgical wound. After surgery, a cast, or better yet, a long boot, is always applied to keep the ankle immobilized. The brace is generally worn for 4 to 6 weeks, depending on the patient's bone quality. As mentioned, the stitches are absorbable and therefore will not need to be removed. For at least the first 2 weeks, it is absolutely essential to avoid getting the foot wet. So ideally, during this period, it is best to avoid showering and try to wash yourself only with a sponge. If you absolutely must take a quick shower, try to do so while sitting and using a small stool. Keep your operated foot off the shower floor. Better yet, use a plastic bag found at the pharmacy. While these bags are airtight, I recommend reinforcing them with a layer of plastic, such as the cellophane you use in the kitchen. For the following weeks, it is essential to try to keep the operated leg raised often. To prevent swelling, swelling is the most common cause of pain, and in some cases can also hinder wound healing. For the same reason, it's advisable to avoid activities like ironing and cooking, as they will inevitably cause swelling even after just a few minutes. Since you can't put weight on the ground despite wearing a brace, you must use 2 crutches or, as this man does, a walker. Only after 4 or 6 weeks after a check X-ray, your surgeon will tell you if you can start putting more and more weight on the operated foot. One of the most frequently asked questions from patients is when they can drive again. The answer is very simple. As soon as your surgeon allows you to abandon the brace in order to wear closed shoes. But initially, it's still advisable to drive short distances because the foot and ankle may still swell during car journeys. Physical therapy is generally started between the 3rd and 4th post-operative weeks. Initially, physical therapy is primarily aimed at reducing residual swelling in the foot, then beginning to mobilize the foot and ankle and helping you walk again without crutches. As with all surgical procedures, there are obviously risks that, although uncommon, should be discussed before the operation. One risk, although rare, is infection, which will require antibiotics. Sometimes antibiotics alone are not enough, and in this case, another surgical procedure must be scheduled to clean the wound in the operating room. As you may have already understood, persistent swelling is another problem, obviously more common in people who already suffer from venous insufficiency. The best strategy is prevention, so always remember to keep your foot elevated. Another potential complication, much more common in heavy smokers or diabetics, is impaired healing. which may require not only repeated advanced medications, but sometimes even surgery. Despite prophylaxis, there is still a minimal risk of developing thrombosis, which may require additional medications taken orally and prescribed under the strict supervision of your family doctor, who may also occasionally request regular blood tests. Sometimes metal screws can cause discomfort. In this case, another operation is required to remove them. In most cases, these fixation devices consist of 2 or 3 screws. The possibility of removing the screws obviously depends on the proper healing of the bone. It must be considered that the bone can undergo delayed healing, and this is more common in patients who smoke heavily or in diabetics. Unfortunately, this delayed healing can sometimes even lead to a complete blockage of bone healing. This complication is called pseudoarthrosis, which, if painful, may require further surgery, not only to remove the screws, but also to remove the bone, but also to redo the arthrodesis, possibly also inserting bone taken from the pelvis. In this case, you're back to square one, having to wear the long boot brace again for 6 weeks without being able to put your full weight on the ground. Another possible complication of surgery is nerve damage to a small nerve that passes near the surgical wound. I'm referring specifically to the sural nerve, which, if damaged or compressed by the scar, can cause reduced or complete loss of sensation on the outside of the foot. As a final complication, I also report a feeling of stiffness in the foot, particularly around the ankle, which inevitably affects the ability to walk on uneven terrain. This problem can be partially improved with the use of an anatomical insole. If you think this video was helpful, or if you think it could be useful to someone else, please like and subscribe to the channel. Thank you.